welcome everyone to this new edition of the 𝐹𝑢𝑗𝑖𝑡𝑎 Alumni Association webinar. First of all, I want to welcome, of course, Professor Yoko Kato, our mentor, konbanwa, sensei. And welcome also to Professor Ishu Bishnoi, my co-moderator, as always. And we have many friends today, as usual, Dr. Liu, Raja, Riccardo, and probably Abida Shah. I don't want to miss anyone, but we have also our two speakers that will talk about very extremely interesting topics. So I want to thank both of them, Dr. Cesare Zoia, from Pavia, Italy, and Dr. Ravikiran Bhutta from India. It's my pleasure to introduce the first speaker, Dr. Cesare Zoia. He completed his training as a neurosurgeon at the University of Insubria in Varese, Italy. And he completed also his PhD training at the same university. He had some experiences abroad, like at the University of Freiburg in Germany and at the Department of Neurological Surgery in Pittsburgh. And he started focusing mainly on endoscopic skull-base surgery, which is one of his main interests. And actually today he's going to talk about endoscopic skull-base surgery. He has been a delegate at the EANS, and he is currently a member of the EANS Young Neurosurgeons Committee. He published almost 60 papers, and his main interest, as I said, is endoscopic skull-base surgery. Today, Dr. Zoia is going to talk about skull-base endoscopy, my personal experience between ENT and neurosurgery. So thank you, Cesare, for accepting our invitation, and you can start your talk.
Thank you, Alberto, for your kind introduction. Thank you for the invitation. I want to say good morning, good afternoon, or good evening to everybody. I start to share my screen, and I start my presentation. As said, is about my personal experience in endoscopic skull-base surgery. And my experience has been always between ENT and neurosurgery. As Alberto said, I started my studies in Varese with Professor Tomei, neurosurgeon, and with Professor Castelnuovo, well-known ENT surgeon, that introduced me to endoscopic skull-base surgery. I want to mention that was an Italian that first successfully removed a skull-base meningioma in late 18th century. And as we all know, the skull base is a complex region. I don't want to go through anatomy, but my lesson will be through three main arguments: the cellular region, the orbit, and the training. And as you will see, all these arguments are between ENT and neurosurgery. And so I will share my personal experience in that. Let's start from the cellular region, the most deepest and complex bone of the skull base, the sphenoid, as we all know. And of course, this is not an anatomy lesson, but as we all know, we have to go through a lot of dissection, and through anatomy to learn about this region and to really understand all the structures that are there. Here, briefly, you see a dissected pituitary region with all the cavernous sinus laterally, the carotid, the chiasma, and the pituitary stalk, and as you can see here, the region of the chiasma and the anterior communicating artery. Without anatomy, you cannot be, without knowing anatomy, you cannot be a good surgeon. That's clear. And so everything started also in the labs with ENT and neurosurgeon that dissect this region and try to understand better anatomy. As we all know, the tumor of the pituitary region are biologically and from an anatomopathological point of view, very heterogeneous. And I want to stress the concept of collaboration, because this lesion includes several options of treatment, medical, surgical, and also radiotherapy, alone or in combination. And this type of surgery must be done in center where all the specialists are present and they collaborate, they really collaborate. These are my ENT, Professor Pagella on the left, and some of my team. Let's start from the history. This region was approached in the so-called pre-endoscopic era through transcranial and standard approaches. After that, the microscope came into the field, and we can call it pre-endoscopic era. But when the ENT start to commit in this kind of approach, and we all know that the first paper is from Joe and Carrao from Pittsburgh, where I was in 2009. And the endoscope era of this kind of surgery started. As we all know, there are different approaches from the basic one, transeptal or paraseptal, transethmoidal, transpterygoidal, to the extended one, of course. And we will see all of that briefly. This is cadaveric transeptal approach, like standard microscopic approach, only see with an endoscope, and you see that it is easy to reach the sphenoid sinus. And but let's start from what the ENT that start to use the endoscope before us, before a neurosurgeon in the 70s with Messer-Klinger, and then we could cite Stamberger and Castelnuovo as just three of big ENT professors that develop all the endoscopic technique. And they start to treat pathology also in the neglect sinus, the sphenoid sinus. And from that, we start to learn how to use the endoscope and how to use the instrument through the nose to reach the skull base. As you see, there are a lot of pathology that are alone in the sphenoid, but the next step, the next normal step will be the pituitary surgery, because the pituitary gland is just behind the sphenoid. And so if we learn from our colleagues, ENT colleagues, to treat the sphenoid sinus, it is possible to go through different kind of approach and reach the sphenoid sinus and reach the pituitary region and treat adenoma or other pathologies, also more complex. As you see here is an example of transrostral, so minimal invasive approach to the sphenoid sinus to reach, just to treat a small microadenoma. And you can see that it's easily to manage the sphenoid rostral septum and to expose the pituitary region. And of course, the approaches should be tailored to what you have to do, how big is the lesion, and how laterally you have to go. We can sacrifice sometimes the middle turbinate, and as you see in the video, it is easy to expose the dura of the cellular region, and then you can go through it and take away your pathology, in this case, another adenoma. Of course, if you want to go more lateral, you can perform a transethmoidal approach and also a bilateral transethmoidal. And then the next step will be a transethmoidal pterygoidal approach, even to go even more laterally. Which are the goals of this surgery? We will see some example, but the goals are to remove the lesion, eliminate and reduce mass effect, preserve and recover functionality of the cranial nerves, maintain and restore the normal pituitary function, prevent recurrences of the pathology, obtain an histological diagnosis, prevent and repair CSF fistula, and dealing with possible complication. I will stress also later, but repair the CSF fistula is something that we have learned from ENT. And I always say to my resident that if you cannot close, do not start the surgery. You have been able to close, because the most dangerous complication is the meningitis, as we all know, and the CSF should remain intracranially. Here is an example of functional pituitary adenoma, and we will go briefly through the video. The goal is just to remove the lesion and decompress the stalk. Is the approach through the right nostril and then also to the left one. And you know, it's very important also to work bimanually and by nostril, as ENT has teach me, and to expose all the dura before opening it, and then go to take away the lesion using a standard, a micro dissecting technique, and you can work sometimes also extracapsular. It's not always like that, and you can take away the lesion and easily manage. And as you see at the end, you will see the cellar tent that comes into the field. There is no CSF leak in this case, so we can just push some hemostatic material and perform a closure with some glue. Of course, it is not always possible to remove everything, but the goal can be also to eliminate or reduce the mass effect, like in this case, or recover the function of the cranial nerves, especially the nerves that goes through the cavernous sinus laterally. This is another standard approach with the sacrifice of the middle turbinate. As you have seen in the images, the lesion is more on the right side. We open in the middle, is an ischemic pituitary adenoma. So there is some part, and we will see that it's a little bit of hemorrhagic component. And at the end, you will see also that we find a small leakage, and we have to repair the dura and to make, here is the leakage, and to make duroplasty. In this case, you have to know how to close using, for example, also the flap, that flap, or a multi-layer reconstruction, or as in the recent year, the Naples school has developed the 3F technique with fat, flap, and fast mobilization. In this case, we perform a multi-layer closure. Of course, this is the postoperative images. Also, to recover or maintain the normal pituitary function, you see in this case a small GH secreting pituitary adenoma with an empty cell, a partial empty cella, that you have to keep in mind just to prevent a CSF leak. Of course, it's a microadenoma. It's not necessary to go for destroy all the nasal part. Just a standard paraseptal approach, and you know that the lesion is in the lateral right part of the cella. You have to expose all the cellar floor, and then just to open where the lesion is and to take away the microadenoma and to preserve the dura, because we know that there is no the pituitary gland behind, but there is still already CSF leak behind this dura in the middle part of the cella, and so we have to pay attention and to prevent CSF leakage. This is the end of the operation, where we check that there is no more pathological tissue. As said, sometimes the histological result can be surprising. You see some example that seems or could seem adenoma, but they are totally different pathology. But after doing some pituitary surgery, you have also to you can also to go through the clivus, through the frontal, the suprasellar space, and transtuberculum or transplanum approach, or transfrontal transethmoidal approach. And so and also you can reach, as we will see in the next few minutes, the orbit. So what is behind your field? You have to care about it. For example, I've put here a big chordoma that can be managed, and I will show you this case of a suprasellar cavernous hemangioma that has bleeding, and the woman has, of course, a visual field defect. We have to go transplant in this case, so we know that we have CSF leak at the end to repair, so we start from preparing and harvesting the flap, and then we open widely the sphenoid sinus, and we expose the dura of the planum. And after coagulating it, we cut it in the midline, and we start to work over the chiasm and under it, on the right side of the pituitary stalk, as you can see. And behind the chiasm, under the communicating artery, the anterior communicating artery, we can find a lesion that is easy to remove with some suction. And at the end, you have also to check with angle scope, 45 or 70 degrees. And also this, the using of angled scope, I learned from a lot from ENT. My ENT partner, Professor Pagella, used a lot the 70 degrees, that not so diffuse among neurosurgeons, but I think it's very, very useful also in intracranial procedure. And you can see with the 45, we can reach also the residual behind the chiasm. Here you can see small receiver that we see with the 45 degrees, and we take it away. And at the end, of course, we put some fat and the flap. In this case, we perform also a multi-layer reconstruction with fascia lata. This is the results, and the patient recovered the visual field and the visual defect. Of course, we can go also through until in the cribbed front plate, so with some example, and we can perform also an endoscopic craniectomy if it's needed, always in team with ENT, in this case of esthesioneuroblastoma. We take away the most of the lesion, and then we perform a endoscopic craniectomy, in this case monolateral, to remove also the dura and to check for the intracranial part of the pathology, as you see. And also in this case, you cannot perform a reconstruction with the flap. We have to perform a multi-layer reconstruction. And also this type of skills I learned a lot from ENT, because they are more expert in this kind of reconstructive surgery. And they start to do that for CSF, spontaneous CSF fistula, for example, and they continued in this way. After exploring a little bit the sellar region, I want to go to another argument that is always skull-based, in my opinion, but is sometimes a little bit the orbit, a little bit of a field of no one, or of a lot of different specialty. As you see, we can manage as neurosurgeon, standard neurosurgeon, manage the orbital content through standard approaches like the crinoline or through the transcranial one. But of course, there are some ophthalmologists that perform orbital surgery, there are maxillofacial surgeon, and of course there are ENT. And the orbit, it's a very complex region and could be also divided into, for simplicity, I can consider the orbit as a target or as an access route, and we will see what this means. Also, in this case, we can find a lot of different lesions, and all are extremely rare. So it's not easy to understand all the pathology that can we face when we perform endoscopic orbital surgery. I like always start from the history, and we have to go back a lot. And I think that in this field, especially with the endoscopic transorbital approach, is a field that is nowadays developing also in the last years. It's very interesting also for us, endoscopic skull-based surgeon. We start from the 18th century with Crinoline, as said, that take away the lateral part of the orbit. You can see here the original crinoline incision. It's not so beautiful to see, but that was. But this type of surgeries, this type of approach is still performed. Of course, during the last century, the approaches go from transcranial type of approach. They develop a lot, but we have to mention Professor Kuba with the frontotemporal orbitozygomatic approach that let us reach the orbital region easily and to manage it. Of course, this approach is quite a lot invasive. We can discuss about that after, but remains something that is a milestone in the skull-based approaches. As said, also for cellular surgery, for pituitary surgery, also here we have to learn a lot from our colleague ENT that before us start to manage some pathology of the at the beginning of the medial portion of the orbit, the medial portion. That means sometimes perform some surgery on the lacrimal apparatus and to perform a dacryocysto-rhinostomy that can be done endoscopically. And then our colleagues start also to do more surgery, and they start to go from medial to lateral. And in the second main pathology that can be addressed through the nose is the Vazlov, the orbital decompression. We can decompress the medial and the inferior wall of the orbit through an endoscopic transnasal access. And here you see the final part of the operation where we cut the periorbita and the fat of the orbit comes into the nose. And you see on the right the post-operative CT scan where the contact of the orbit comes into the nose and the graves of ophthalmopathy is resolved. Of course, after that, I always see a group of ENT start to remove some intraorbital tumor or some interorbital cavernous hemangioma that is quite frequent in this region. And it can be done through a minimally invasive approach. It's we perform a plastic of the middle turbinate, we take away the uncinate process and we open the bulla and we expose the papyracea and the periorbit. And after doing that, you can open the middle wall of the periorbit and you face, of course, the fat and the muscle that are in the orbit. You can see here the middle rectal muscle, and behind it there is the lesion that can be nasalized, said, and then after that can be, of course, little bit of coagulation of the pedicles of the lesion, and can be taken away through the nose. You can see on the right post-operative MR. Of course, you can manage also bigger lesions that are also extracorneal or also intracorneal lesion. To respect the golden rules of the sun, do not cross the nerve, the maximal that you can manage through the nose, through an endoscopic transnasal approach, is the pathology of the optic nerve, because in this case you see a big optic sheet, nerve sheet meningioma that can be, we can decompress the orbit, taking away some of the pathology through an endoscopic approach. And this is the maximum that we can reach through the nose, the optic nerve. But of course, as said, in the last 10 years, also the endoscopic transorbital approach has been developed. And also in this case, we have to say thank you to our ENT colleagues that start to work in this kind of approach. And the first paper is from 1981 from ENT. And here you have the paper. And that in the last 10 or 15 years has been developed by ENT and neurosurgeon. And I would like to cite the school of Varese and Jacopo Dallan, that was the first Italian that studied this approach also in the lab. As said, also in this case, it's very important to go in the lab, make a little bit of dissection and understand what we have to do then in real patient. Here you can see some picture of our last dissection where through transorbital approach is possible to expose the middle cranial fossa and reach V3, V1, V2, the lateral wall of the cavernous sinus, and after a little bit of work also the posterior cranial fossa, as you see in the images. Of course, we can perform a different kind of incision for this surgery, trans eyelid or a supraorbital one. With a supraorbital, you can perform two types of approach: standard supraorbital approach and a transorbital one. And here are the phases. And of course, if you put the endoscope in a supraorbital approach, the region that we reach, it's here top of on the right of the screen. You can easily understand how can you what you can reach and see and manage. And here was our paper about our technique in endoscopic transorbital surgery. And here's the original video with the pathology where fibromyxoid sarcoma, so a pathology of the lateral wall of the orbit. As you see, you can easily start the bony work and isolate the pathology, and then remove it. And at the end, you have on the side the temporalis muscle, and on the back the dura of the middle cranial fossa, and on the upper side there is of course the anterior cranial fossa. This is another case of transorbital approach. In this case was an intraconal ectopic meningioma of the posterior region of the apex of the orbit. We open the periorbit just above the lesion, and we can find the lesion and remove it with a standard endoscopic technique. And in this case, there is no problem in the reconstruction, just some fibrin glue, and the orbit makes all the works. And of course, we can go through the orbit also with an inferior eyelid incision when the lesion is in the inferior part, and we can use also the endoscope to better visualize in some part of the operation and to remove also big tumors, or in this case cavernous hemangioma, through small incision. And to close it, just some fibrin glue, and the results. It is very cosmetic. This is just 2 days after the operation, and you see the CT scan. But as said, the orbit can be also an access route, and through anterior middle cranial fossa, cavernous sinus, and also to posterior cranial fossa. Also here, our colleagues from Varese developed published some papers about that, and I briefly show also this video of a meningioma that has a big bony part that goes to the orbit and invades the orbit, and it can be managed through an endoscopic transorbital approach, removing the bony part at the beginning, and then exposing the dura, and removing the pathology. And at the end, you have a beautiful perspective on the Silvian fissure from the front, and that is not quite common. To reconstruct, you can perform a duroplasty, and with some glue, or of course with multiple layer, and the orbit makes all the work. I want to stress this concept, finishing my presentation for the orbital part, that we are still in progress, as to say, this kind of approach, and we believe that it's this kind of approach, the transorbital endoscopic approach, is a valid surgical path for orbital sphenoorbital pathology, but its real benefit for intracranial pathology has yet to be demonstrated. There are a lot of papers from some famous colleague that has started to publish series of intracranial pathology. They are very interesting, but of course we have to proceed very, very step by step. And if the orbit can represent a natural path when the pathology occupies or invades it, using it purely as surgical corridor to approach intracranial pathology can present some risk and some technical difficulties, and you do not perform this surgery straight away. You have to have a learning curve through all the traditional, as to say, approaches, and also to standard endoscopic procedure before through the nose, and to gain some experience. And the last 2 minutes of my presentation, I want to stress some things on training. As said before, training is very important, and I learn a lot from ENT also in this case, because I attend a lot of dissection courses from different kind of colleagues, and I see that without that I cannot perform surgery safely. But we develop together with some friend another concept that is gaining popularity in these days, that is the concept of hybrid training. So we designed, and we have already performed two editions of this kind of courses. We design a course that is hybrid, and we start the first day with some less theoretical lesson and some dissection on simulators. And on the second day, we perform all the same procedures on cadavers. And we have seen, and we are going to publish also our results, that the learning curve gain a lot, and this kind of training will gain popularity in the next years. And the simulation is also very useful where it's not possible to use a cadaver. I'm thinking to lower incomes developing country, or also when you have to train a little bit, but you cannot reach a lab or an operatory room. So we strongly believe that simulators have a role in training the next generation of surgeons, and also virtual reality, mixed reality, augmented reality will play for sure a role. To conclude, I want to thank you, my ENT partner, Professor Pagella. Here we are in the Italian ENT National Congress. I want to thank you all my friends and colleagues that in these years helps me to develop my skills in endoscopic skull-based surgery. And I want to leave with some conclusion. Be always prepared to face the unexpected. Travel a lot and share your experience. Never stop learning, especially from your mistakes. And stay always in touch with the masters. That it's mandatory to have someone that can teach you every time. And the last but not least, also the most important message is that teamwork is the key to success. So I want to thank you for your attention, and again for the invitation, the opportunity to speak in this webinar. Here are my social account, and I'm here to answer all your questions. Thank you very much.
Thank you, Dr. Zoia. Thank you, Cesare, for this wonderful presentation about skull-based surgery, in particular about endoscopy. And I want to point out the collaboration key point that you stressed a lot. So I think we can start our discussion. Maybe Professor Yoko Kato wants to give some comments just to begin our discussion.
Thank you very much, Zoia. There's so many times for contributing to the educational activity. So I was so impressed the skill and also the idea how you can reach the pathology. And sometimes do you do the combined, some supraorbital and also the transsphenoidal according to the pathology, how do I say, itself? So just the please. And also the second one is in the future, maybe the ear hybrid hands-on workshop is really, I think, worthwhile for the younger generation. So is it possible to share or collaborate our SNS and the YNS?
Thank you for the question. Of course, the multi-corridor approaches are very, very useful when the pathology is in the border or extend from the nose to the orbit or to the middle cranial fossa, and you can use different corridors and combine them to reach the pathology and to manage it. So it's mandatory to have all these different approaches, also the standard one, of course, but of all of this skull-based endoscopic approach, and you can put it together when it is necessary, because as we all know, we have to keep the approach as small as we can, but as big as we need. And yes, this kind of we have seen that this kind of hybrid courses and the courses also just with the simulation are very useful, especially for younger residents to understand the anatomy, to understand how to use the instrument. Because sometimes you go to the cadaveric dissection and you cannot perform a drilling of the skull base through the nose. And it's not respectful, I think, to the cadavers, also to the donators, that you destroy simply the anatomy and you cannot understand what you are doing. So we think that the simulation is the first step to reach the cadaver and to gain a lot from them. And of course, I personally, but also my colleagues are totally at your disposition to organize something together. It will be a pleasure for sure. Thank you.
Thanks so much. It's a wonderful talk. Thank you very much. Congratulations.
Thank you. Are there questions for Dr. Zoya? Yes, issue.
Thank you for the wonderful presentation, Professor Zoya. And the question was like there was a small sphenoid wing meningioma which was approached through transorbital approach. And my question is like rather than going through orbit because that tumor was quite small, can we do just going laterally through making this incision so that we can totally avoid the orbital content and because the orbit is the periorbita, the slight damage to periorbita can lead to the fat coming into your view, and the damage to that periorbita can cause lateral pain and hemorrhage. That's why avoiding the orbit, and we can directly go through making lateral orbit of this incision and go to the area without opening the orbit. So
thank you for the question. Of course, it's a possibility. I always say don't be dogmatic. If you have a tool, you do not have to always to use it. The transorbital approach for this kind of pathology could be an option, but of course the standard approach with a crown line or with a minipterional or suborbital approach can be done. It depends, in my opinion, of how much the lesion goes in the orbit or not. Because if you perform, for example, a minipterional, the bony work and the reconstruction phases are more invasive because you have to take away some bone that is sane and that you have to re-put in place. If you go through the orbit, the bony work is just the lesion, and the reconstruction is not needed. But of course, you are totally right. This kind of approach is not, I don't think it is not a competition or just to, you have to have different option and to customize for your patient and also for your skill. Because if you are more confident with endoscopic approach, go through the nose or through the orbit. If you are more confident with a standard approach, go for it. It's not a question. It's just one possibility. So thank you for the question, because it's a concept that we have to stress. Sometimes during this discussion, there's someone that said, I can do endoscopically, let's go endoscopically. It's not always like that. We have seen, for example, I have shown a big anterior cranial fossa meningioma that was done in the past through the nose. Nowadays, nobody goes through the nose because it takes too much time and the reconstruction phase is difficult. But sometimes there are meningioma that goes also in the nose. So sometimes you have to combine or to go through the nose. So it's just a question that you have to learn a technique and then use it properly.
Yeah.
Thank you.
I have one more question. Like,
yeah.
After in some pituitary tumors, have you ever faced that after doing transsphenoidal surgery, patient and total removal of tumor, despite that after 1 year, 2 year follow-up, patient repeatedly complains of headache, which is intractable, and like because my 2-3 patients of acromegaly, they have that kind of headache after, specifically after a transsphenoidal approach, that they suffer from severe headache, and it's severe, not manageable with medications. Have you ever faced such kind of patients, and how do you manage like that?
Personally, I have not faced this kind of case, but I have some colleagues that told me the same, but not only for transsphenoidal approach, also with transcranial one. And we cannot really understand how to manage this type of headache after an operation, but we have to try different medication and different drugs. It's not easy. I was lucky till now, maybe, but I have no experience after transsphenoidal surgery.
It's not a question, like it's I want some professional advice, because I am facing 2 or 3 cases. Like anybody has ever faced such kind of headache after transsphenoidal surgery. Maybe Alberto, Professor Abida.
Actually, I have no memory of this precise correlation between transsphenoidal surgery and severe headache. Honestly, no, I don't have such cases. Abida?
The headache occurs for some days, maybe a month or so, but after that it goes away. I mean, it's typically associated with the transsphenoidal, but it should go within 15-20 days or a month at the most. Doesn't remain beyond that.
Like I made some hypothesis after reading some papers that because of the prolapse of optic nerves or traction, because we removed the tumor and it caused the negative pressure on the but there was no proper treatment. I tried like naproxen, amitriptyline, antidepressant. So I have one patient which intractable headache. I'm just giving antidepressant full dose. Like maybe that can help. Anyways, Dr. Atiq Islam.
Yes, we have a question from the audience. Maybe. Okay, Dr. Islam.
Okay, thank you, sir, for your brilliant presentation. I am Dr. Atiq from Bangladesh. In our center, sometimes we found some acromegalic cases that huge pituitary macroadenoma invading the cavernous sinus, and sometimes it becomes very difficult to remove the total tumor through endoscopic approach for cavernous sinus invasion. In these cases, do you suggest a combined approach, or is it at all possible to remove the total tumor through endoscopic approach when there is huge cavernous sinus invasion?
In my opinion, when there is, for example, a acromegalic patient or secreting adenoma, of course, not for prolactin, but for the other hormones, the treatment, the first line treatment is surgery, and you have to remove all the tumor, as we know. I think that cavernous sinus, when there is an invasion, you can follow the lesion, and you can manage the pathology through the nose. We have in Italy the School of Bologna with Professor Frank, and then with Professor Mazzatenta and Dr. Zoli, that have published a lot on this kind of surgery, and cavernous sinus could be managed. Of course, sometimes you have to follow the lesion in the cavernous sinus. Sometimes it's not so easy. Of course, it's a demanding surgery. It's not the first step surgery. I mean, it's not a question. Is a small micro adenoma? It's easy. It depends where it is or where it goes. So adenoma doesn't mean easy, but it can be done with some little bit of experience. Can be done through the nose.
Sir, is there any option of radio surgery for this type of cases to prevent recurrence?
Difficult question. You have to, of course, the first surgery is the main and the most important one. You have to check behind the angles for small residual, and using the angle scope, especially in my opinion, the 70 degrees, it's very useful. But apart from that, it also depends from the lesion. If it's diffluent, it's a thing. If it's hard, is another thing. But check for all the corner. It's one easy suggestion that I can say to you.
Thank you, Dr. Islam, for the questions. Cesare, I also have a couple of questions for you. The possibility to operate inside the orbit with an endoscope is very fascinating, of course. I want to ask you if you have experience about optic sheet fenestration for conditions as pseudotumor cerebri. Is it possible, as you show that it's possible to reach the optic nerve and manipulate the optic nerve through such an approach. So I would like to know if you have any experience in optic sheet fenestration using an endoscope. And the second question is about the collaboration and interaction between us, neurosurgeons, and ENT doctors. In my experience, when I was in Modena, I always did this kind of operations with an ENT. And here in Verona, it depends on the case. For some historical reasons, you know, it depends on the institution where you work. In some places, neurosurgeons perform transsphenoidal surgery by themselves. In other institutions, they always operate with ENT. So here now we select the cases. In simple cases, we perform surgery by ourselves. In complex approaches, we collaborate actively with ENT. So I would like to know your opinion about that. Do you always work with an ENT, or it depends on the case?
Okay, thank you for the question. About the first one, I have no experience of optic nerve sheet fenestration, but I have a concern about that, because if the optic nerve is pathologic, so it's much bigger, like in optic nerve sheath meningioma, it's already difficult to manage it. If the optic nerve is quite normal and you have just to reach it, it can be very difficult. But theoretically, it can be done, of course, both from the nose and from the orbit. It's possible. I have not faced till now a patient that need it, but it can be done. Also in this case, the intraconal pathology, it's even more difficult than the intracranial one through the orbit, because when you cut the periorbita, as we all know also from transcranial approaches, the fat came into the field and it becomes a mess. You get lost every time. You have to just to relax a little bit, breathe, and then start to find your pathology or your anatomical relationship between the muscle and so on. And so I do not suggest to go for intraconal pathology for first operation with this kind of technique. Regarding the collaboration, of course, if you became an expert endoscopic surgeon, I don't say ENT or neurosurgeon, but endoscopic surgeon, you can perform everything also alone or with your colleague that is neurosurgeon, or ENT and ENT. Because most of the time you need the second operator or to take the endoscope for you or to help you. It depends also from the schools. But what I want to stress, I truly believe in collaboration, not always for the technical, practical point of view. A lot of time it happens that I ask to ENT guys and ENT ask to me to came into the room and to stay there, maybe just for the central part of operation that is just neurosurgery or just ENT stuff. But having another two eyes that are that are slightly different point of view from yours, because I have another background, it's very important. That's the main question. It's not a question having two hands or four hands, because you can train a lot of people that are just neurosurgeon or just ENT, and they can perform spectacular surgery. But it's a question of having two brains, two different point of view. That's the main point for collaborating. And of course, I will lie if I say that I operate always with ENT, because sometimes we do not have the possibility, because the operatory room we are together. Sometimes we are on guard. There is also the urgent cases and so on. But I always ask for someone. Sometimes I just say also to a resident of the first year that of course cannot help me, because it's not in the right phase of the training, but I want that someone is there. So when I can, I always operate with someone, and operating means having the ENT there. Maybe I perform all the surgery and he's just there watching, and I do the same in his operatory room, but having another brain that is not from your background, it's very, very important. It gives you something more in the operation, in my opinion.
Yes, I totally agree with you. It's very, very important to learn from each other. Of course, we also have the same problem you have. It's not always possible to have both competencies at the same time in the operating theater, but if possible, I also am a strong believer of the benefits that the collaboration, the active collaboration, is as many cases as possible can bring. Is there any other question from the audience for Dr. Zoia? So if there are no other questions, I want to thank Cesare Zoia for the nice presentation and the very active discussion. I think very useful especially for young neurosurgeons. Thank you, Cesare. And we can move to the second speaker. And so I would like to ask 𝐹𝑢 Bishnoi to introduce our next speaker. 𝐹𝑢, can you unmute?
Thank you, Albert. So I would like to invite our next speaker, Dr. Ravikaren Bhutha. He is a neurosurgeon from India, and he did his neurosurgery from King Edward Memorial College, Maharashtra, in 2018. And he has special interest in deep brain stimulation, epilepsy surgery, and he has been trained from University of London and had his certificate about neuromodulation. Currently, today he will be speaking on management of epidermoid tumor in brain. He has published around 30 papers, mostly about deep brain stimulation. And I would like to invite him to present his presentation about epidermoid tumor of brain. So please, Dr. Ravikaren.
Thank you, Dr. 𝐹𝑢, for those kind words. Can I just share my screen first?
Yeah.
So right at the outset, can you hear me well enough?
Yes.
Yeah, thank you so much. Right at the outset, I thank Professor Kato Madam for providing me this platform to present my work. As also, I would like to thank and mention my mentor, Professor Atul Goel, under whose tutelage I've learned everything that I know in neurosurgery while in KEM, and I'm proud to be associated with him even after finishing my stint from KEM, as also with Dr. Abida Shah, force to reckon with in neurosurgical practice. So my topic for today is the surgery for epidermoid tumors of the brain. Now, epidermoids, as we all know, are congenital lesions that are retained from the ectodermal lining while it forms the neural tube, usually between the 3rd and the 4th weeks of gestation. They present around 1 to 1.8% of all intracranial tumors. Usually they're congenital, however, they can be acquired after surgery or trauma. And usually they present around the 4th decade with no really gender predilection. So these epidermoids are usually very slow growing tumors. They grow very discreetly and they grow wherever there is space as such. They're not exactly either ectodermal or neural. They're a mix of both. They usually are very slow growing and have very non-specific signs and symptoms for their presentation. And usually their symptoms are based on the compression of the adjacent neural or vascular structures. Headache and seizures have been reported as symptoms. However, rapid onset symptoms can occur secondary to hemorrhage, trauma, rupture with chemical meningitis, and acute brain edema. They can be present, majority of the cases are present in the CP angle and the basilar artery region. They can be present in the paracellular, supracellular region, or rarely in the Sylvian fissures, supracellular, cerebral or cerebellar hemispheres, lateral or fourth ventricles, spinal region, cavernous sinus, or maybe even intradiploic within the bone. It's a histological picture showing the keratin layers. These present usually in the cisternal spaces, and hence the anatomy and the knowledge of the anatomy of the cisternal spaces is vital for surgical approach for any of these cases of epidermoid of various size. They might be small, but having close proximity to the vascular and the neural structures makes surgery for this precarious, especially because the patients preoperatively usually do not have any deficits. Here's an example of a Sylvian epidermoid. The anatomy of the Sylvian fissure is very important to know here. He is an example of a supracellular epidermoid. You see the MRI and the CT. The anatomy of the cisterns of the anterior skull base, that is the lamina terminalis cistern, the optic chiasma, the carotid cistern. As you go posteriorly, the interpeduncular, the crural, the ambient cistern, and posteriorly the quadrigeminal cisterns. The anatomy of this and the structures within pose a challenge to the surgery. Similarly, lesions presenting in the posterior fossa, as we need to know the anatomy of the CP angle cistern, the supracerebellar cistern, and the pineal region, that is the fifth, the sixth, the lower cranial nerves, the vessels, the supracerebellar SCA, the ICA, PICA, the cerebellum, etc. An endoscopic view of supracellular cistern, where you see the ICA, the A1, A2, the opposite A1, A2, the optic nerve, the optic chiasma, etc. Interhemispheric epidermoids, the anatomy of the interhemispheric fissure, the surgical approaches for the same, localizing it, avoiding injury to the superior sagittal sinus, the presence of the pericallosal vessels, the corpus callosum. Intraaxial epidermoids are present within the ventricles. Here is an epidermoid is present within the lateral ventricle. You can hardly see it on the scan. It is usually present, in this case, it is present within the region of the trigone of the lateral ventricle. All epidermoid is present within the fourth ventricle. The fourth ventricle, even though the surgical approach might be easy here in this case, but the challenge lies while removing the peeling off the capsule of the floor of the fourth ventricle, wherein the patient can have deficits. Some rare presentations published here with Sylvian fissure epidermoid cells presenting with intention tumors, intention tremors. You see this patient here with the Sylvian epidermoid, the diffusion restriction here, and the post-operative removal, and the patient improved from his intention tremors. Another rare presentation which has been published here by Professor Goel is of CP angle epidermoid presenting with the tic convulsive. That is, the patient has both trigeminal neuralgia and hemifacial spasms. Concomitant tumors, that is the presence of CP angle epidermoid and a pontine glioma, or a CP angle epidermoid and a squamous cell carcinoma. All these papers have been published just to show the various presentations in these cases. Cavernous sinus epidermoids, the anatomy of the region is highly important to know. It involves the optic nerve, the ICA, the third, fourth, fifth, sixth nerves. They can be multi-compartmental. Here you see them extending from the posterior fossa, going into the medial temporal fossa and the supracellular fossa. You see the epidermoid tracking along the fifth and the sixth nerve here, going towards the cavernous sinus. You see the excision of the tumor and the post-operative scans here. This is a case report based on such large, giant, multi-compartmental epidermoids. Professor Goel has also described this particular cavernous sinus epidermis, which are truly actually interdural, not within, but interdural in their approach, which makes the surgery quite safe. Large, giant cavernous sinus epidermoids, pineal region epidermoids. They're present in the cistern. We usually approach it by the supracerebellar approach. I will come to in details. Epidermoid present within the third ventricle. Giant epidermoids extending from the anterior fossa to the middle fossa and to the posterior fossa. Some epidermoids which are present anterior to the brainstem, encasing the basilar artery completely. So these epidermoids in synopsis are slow-growing tumors. They can be present anywhere in the brain. Usually, they are present in the cisternal spaces. Tentorial-based epidermoids, which are usually present in the posterior fossa, very adjacent to the tent, extending either supratentorially or anterior into the suprasellar space. This was a paper presented here from KM of 96 cases. Here are some examples of these giant posterior fossa tentorial-based epidermoids. You see this, in this case, it is present in the CP angle. It extends supracerebellar, supratentorially, and it extends anteriorly into the medial temporal and the suprasellar regions. Large tumors, you see this patient who's been operated, again, the tumor extending into the cavernous sinus here. So these are some examples. You see here the epidermoid present on both sides, extending around the brainstem, draping from the right, going to the left, and extending onto the suprasellar space. So in our study, we found that they were predominantly in the 20 to 30 and 31 to 40 years of age group. The common duration of presentation was around 6 months of age. Now, anatomically, what we found during surgery was that the patients, the tumor usually displaced the fifth nerve maximally laterally. The 7th to 11th cranial nerves in the CP angle were present, were displaced laterally. The 6th nerve was displaced anteriorly and inferiorly. The tumor could extend into the cerebello-brainstem fissures and go anterior to the brainstem also. Usually the membranes are intact. They can extend above or below the tent. The most common presentation was that of headache, followed by gait disturbances, facial numbness, vertigo, hearing deterioration, diplopia, neuralgias, facial spasm, vision deterioration, seizures, vomiting, memory loss. Now, when we approach these patients for surgery, there are certain points in favor of surgery which make the surgery feasible, and that is the fact that it is a soft and suckable tumor. The brain is usually lax. It's an avascular tumor. However, what makes it challenging is the fact that it distorts the anatomy of the brain, the cranial nerves, and the blood vessels. They may encase the blood vessels all around, especially the small perforators, damage to which can be very detrimental to the post-op recovery of the patient. And the fact that it can be multi-compartmental, and choosing an approach based on this is very important in preoperative planning. So when Professor Goel described this surgery for such large multi-compartmental tumors, the surgery that is proposed is for a CP angle and the tumor extending towards the incisura or supratentorial, is surgery through the supracerebellar approach first. Secondly, if required, to extend the incision in the tent and go supratentorially. And last, to go to the CP angle. So the three stages: the lateral supracerebellar, the supratentorial through the tent, and the resection of the CP angle part. Here are some examples of giant tentorial-based epidermoids. These tumors you see can extend into the supratentorial also, and the surgery performed. I will show one video of the same and the post-operative resection. Here's one surgery that is particularly impressive, is because it extends right into the suprasellar cistern. And this particular case, you can actually see almost cranial nerves 2 to 12 in this one case. So the first case is to drain the CSF from the cisterna magna and make the brain as lax as possible. Second is to go through the supracerebellar approach, you see the fifth cranial nerve here and the tumor tightly present. That nerve is pushed laterally. Once we achieve this, we go further anterior towards the suprasellar region, and once you deliver the tumor from here, you start seeing the fourth nerve while it is being brought down. That is the fourth nerve while it is being brought down. The fourth nerve here. Once it is carefully separated from the fourth nerve, you can see the third nerve here. Once it has been separated, as we proceed further anteriorly, we start seeing the structures present in this suprasellar region. This is now the carotid, the optic nerve, this is the hypothalamus, and this is the pituitary stalk. Then we come to the lateral CP angle region, where we separated from the 7th-8th complex and the lower cranials as they exit the brainstem. We note that the tumors can extend anterior to the brainstem also. And while this is performed, they are in close association now with the vertebro-basilar artery and the perforators very close to this. Just checking for the tumor all around the CP angle, the supracerebellar, and anterior to the brainstem. Another tumor, just another video, just to show the dense association of the perforators next to the basilar artery and the resection of the tumor, making sure that these perforators are not harmed during surgery. So these are some scans and some postoperative images. We're using this particular approach, the supracerebellar, the extending into the tent, going across the tent, and then going into CP angle. You see the postoperative images here. The brainstem is very, very distorted in the preoperative state. Gradually, it comes back to its position. Next would be the pineal region epidermoid. The pineal region has its own challenge, the critical nature of the vasculature there, and the presence of complications. Both CP angle and pineal region, we prefer to do in sitting position. We have trained anesthetists who are very well versed and are capable of keeping an eye out for air embolism and features of so. The pineal region epidermoids have the location which is right at the posterior end of the third ventricle, the midbrain. They can extend, they might be either central or they can extend to one particular side. You see the resection here. In this case, is a little lateral to the midline. Giant pineal region epidermoid extending more anteriorly. The anatomy of this region is of particular importance because it drains the central basal veins, the internal cerebral vein, the vein of Galen, the information from the CT, the proximity to the P2, P3, P4, the pituitary tumor as such, the pulvinar of the thalamus, the lateral choroidal vessel, the internal cerebral vein, the basal vein of Rosenthal, this inferior sagittal sinus, the splenium, ultimately forming the vein of Galen here going into the straight sinus. There's some intraoperative images showing the same. There is usually a various thickness of arachnoid here, which has to be crossed before you actually reach the region of the pineal. This is the PCA, the superior cerebellar artery. This is the vermis of the cerebellum, the tentorial edge. We usually prefer the supracerebellar midline infratentorial approach, which is the natural corridor between the cerebellum and the tentorium to reach the pineal. There are other approaches which are paramedian or occipital transtentorial approaches or posterior interhemispheric approaches which are present, but we prefer the supratentorial midline approach. It's the shortest and it has given us great results. Suprasellar epidermoids, only isolated to suprasellar region. These have their own challenges in terms of the anatomy of the anterior skull base. There are some tumors which are present in the suprasellar region going posteriorly towards the brainstem, and these MRI images of the same. Large giant suprasellar epidermoids which are present here. The anatomy of the anterior skull base includes the critical structures, that is the optic nerve, the internal carotid artery, the third nerve, the anterior clinoid process, the temporal lobe, medial temporal lobe, the sphenoid sinus, the branches of the ICA, that is the ophthalmic artery, the superior hypophyseal artery, the pituitary stalk, and the pituitary gland itself, and the inferior hypophyseal artery. Lastly, a rare phenomenon, white epidermoids. Usually epidermoids are hypodense on CT, hypo-intense on T1, and hyper-intense on T2 images. But if we have the exact opposite, where there is mild hyperdensity on T1 and mildly hypo-intense on T1 of the MRI, and slightly less than T2 CSF attenuation on T2 images, then we must have at least a differential of a white epidermoid in mind. These are some examples of white epidermoids. You see this mildly hyperintense on the T1 image on both sides here. White epidermoids usually is present in the sellar, suprasellar region, middle cranial or posterior fossa. The intraaxial presentation is usually very rare. The high attenuation on CT is because of diffuse calcifications and saponification of the internal debris of the epidermoid. It is believed that the dense aspect of the epidermoid is related to diffuse calcifications. It is also thought that there might be minor leaks which happen from the epidermoid, which lead to more exudative defense reactions, which give rise to a more dense picture, both on CT and on MRI. There is a higher incidence of capsular invasion when you start considering white epidermoid cysts, and there is a risk of chemical meningitis during these surgeries, and that is why preoperative having a differential in your mind when it comes to white epidermoid is important, so that you plan the surgery without risking chemical meningitis. The differential diagnoses include dermoid cysts, neuroenteric cysts, craniopharyngiomas, melanomas, and cavernomas. And then here I would conclude that surgery of the epidermoids, the nature, the soft nature of the tumor makes it the surgical removal safe enough. However, the safety of the cranial nerves, the blood vessels surrounding the epidermoids is what presents the challenge, apart from choosing the right approach, the trajectory in the surgical excision of these tumors. Thank you.
Thank you for the presentation, Dr. Ravi. So the house is open for the questions.
So may I ask
Yeah.
question? Thank you, Dr. Vuta, for the nice presentation about a fascinating tumor. It's always rewarding for the surgeon, I think, to deal with an epidermoid tumor. They are so nice looking, so bright color, but as you said, they are benign in nature, but that they are also tricky, because if you leave a small piece behind, they will recur. So I have a comment and also a question. My comment is that in my experience, I found it very useful to double check the surgical field at the end of surgery using In the past, we use a small mirror, but nowadays we have wonderful endoscopes. So I think the use of the endoscope at the end of microsurgery can add a plus to resection. I have precise memories of patients, of surgeries, where I was quite sure after the microsurgical part, I removed everything, and then I placed an endoscope inside the surgical field, and I found a small piece around the corner, you know. So I would like to know your opinion, and also your daily routine on the use of the endoscope or other means to be sure that you removed everything. And also, I would like to know how do you manage relapse? I mean, of course, these patients must be followed up. What do you do if you see a relapse? You just follow up, you do surgery immediately? What's your attitude? Thank you.
Well, sir, you raised a very pertinent point. We too have, and Professor Goel also has used the advantage of an endoscope to look across the corners at the end of surgery, and it does help if there are any small bits of tumor left there. In fact, now the latest ZEISS that we use has an attachment which acts as an endoscope in a microscope, and that has added a great amount of luxury to our surgeries as such. In spite of radical approaches to the surgery in epidermoids and the fact that you can remove almost the entire tumor, the bits that are attached to the vital structures, for example, the floor of the fourth ventricle or the basilar artery, are the ones which are usually left intact so that the patient is preserved at the end of surgery. And they can come up with recurrences, and our policy is usually to follow them up with serial MRIs and to see how fast the recurrence is growing. And when they are symptomatic, back again is to reoperate.
So based on symptoms mainly, and
yes, yes.
How fast they
yes,
they grow.
yes.
Okay, thank you. Ishu, I think Dr. Zoya wants to ask a question. Cesare?
Thank you for your wonderful presentation. I want to ask you, so you have shown a huge experience. If you have experience of malignant transformation of residual, and if you have experience also in primal intracranial squamous cell carcinoma, so already malignant at the first operation. Because I faced the case of a primary intracranial squamous cell carcinoma. It was a disaster. After 1 month, we have metastatic lesion all over the nervous system, in the spine and in the cranial, and the patient died after 2 months. So I totally agree that are benign tumors, but in a very, very small percentage they can become aggressive or be aggressive already at the first time. So I want to know your experience about the malignant transformation of these tumors. Thank you.
Well, honestly speaking, malignant transformation or right at presentation is not something that I have seen in my experience, but there was one paper presented with a concomitant tumor of a squamous cell carcinoma. But honestly, it's nothing that I have experienced in my last 8 to 10 years in association with Professor Goel. Maybe Dr. Abida would be able to add to it.
Yes, thank you, Ravi. Professor Zoya, we had one case where the patient had a collision tumor of a brainstem squamous cell carcinoma with a epidermoid in the tentorial notch. So we removed the epidermoid, and the brainstem tumor we just biopsied, and it came out to be a squamous cell carcinoma. The patient didn't do very well. He was okay for a few months, but then he succumbed to the brainstem tumor. But a primary malignant epidermoid tumor I have not seen. I have also seen another interesting case where the patient had a chordoma and we operated the chordoma through a middle fossa approach. And he came back with a recurrence, and that time he had 2 tumors. He had an epidermoid in the region of the approach, and then the recurrent chordoma. So then I operated and removed both. And then the third time he came with a recurrence, and there was only epidermoid, no chordoma. So these are the 2 interesting cases that I have come across. But I have not seen a primary malignant transformation of the epidermoid.
Thank you.
And for the last case, what was the explanation?
Of which one?
The chordoma.
Chordoma, I think it was probably the seeding from the skin or something like that transformed into the epidermoid. I'm not sure what it is. And it just keeps coming back. This patient is now, I think, 72 years old, and he still has some tumor, but he's not that symptomatic, so I'm following him up.
Okay. Grossly interesting. So do we have any other questions? Professor Yoko, ma'am?
Thank you, Rabbi Kiran. It was an excellent talk.
Thank you,
Yes, I
ma'am.
wanted to ask, because Dr. Zoya, that he presented a very nice endoscopic procedure, and epidermoid itself is very soft, and also it's a good indication for endoscopic procedures. Just it's easy to regrowth once we left some piece. So what about this? Do you use remove of the capsule itself? Because if you remain the capsule, it's easy to regrowth of the tumor. So I think less invasive the treatment is better than the big open the craniotomy. How do you think about it?
Very true, madam. But our experience is more in the open surgery, very less in endoscopic approaches. As far as removing the capsule is concerned, we attempt to remove it entirely based only when it is adherent to vital structures, for example, the cranial nerves or the blood vessels. That is when we leave that little bit behind. But apart from that, the approach is to be as radical as possible while being as safe as possible, and preventing as much as chance of recurrence as is possible.
How
Thank you.
about Dr. Zoya? How do you think about
Yeah,
strategy?
I agree, of course, with my colleague. It's endoscopic approach could be an helpful tool, especially for the last check, as Professor Feletti said before. But it depends also on the size of the lesion, the region of the lesion, and so on. And of course, sometimes you have to leave some capsule behind. If it's possible, take it away, of course. But sometimes it's not possible because the risk of damaging a nerve or a perforator is too high. And we know that it will be a recurrence in the future, but we have to follow up our patient. And the first thing is not to damage a nerve or a perforator, because, as said, most of the time they have just headache, or it is an incidental finding.
Yes. Thank you very much. Issue?
Yeah, I have experienced only open surgery of epidermoid tumors, and I have never used endoscope after doing open surgery. I use endoscope only for pituitary surgery, but I would like to, and I agree that using endoscope, it can give you an idea because of the residue, because it's a avascular tumor. If surgery is performed very nicely, so there is no blood loss or bleeding there, so it can correctly visualize the residue which is there inside the corners. As mentioned, Dr. Ravi already mentioned that corners can be checked.
Because we have so many cases because of trigeminal neuralgia or hemifacial spasm. So once we can make some space, piece by piece, by endoscope, and then we can have a large weight to the end of the tumor.
Yeah, I think we should see the endoscope in these cases not like a replacement of microscope, but as an adjunct. Right? So nobody wants to say that we have to throw away the microscope because now we have the endoscope. Probably masters would be able to perform this kind of surgeries using only an endoscope, but for normal people who are 98% of neurosurgeons, probably that would take too long timing. And time is also important in the operating theater because of many reasons, infections and so on. So we must look at the endoscope for such cases as a very important tool to double check at the end. You should try issue. It's very, very nice. You can find, discover small pieces of tumor that you would never imagine to find.
I would, and I am planning to start endoscopic trigeminal
Please,
MVD.
yes.
That is my next step.
I think it's a very, you can save the time because you can reach the pathology as soon as possible. So maybe the very small incision, very small part, it's very save the time, I think.
Yeah, for trigeminal neuralgia, yes, it's good, it's true. Yeah.
Abida, you want to say something? You're the boss.
No, I think for epidermoids, microscope first and then endoscope to check the corners. So this new microscope Kinevo has that Kivo tool, and it works very well actually. You can put it inside and then rotate with the, with the microscope itself and see all the corners, superior, inferior. So that is definitely a good tool. But epidermoids are like, they have made the space for you already. They've opened the fissures, they have splayed everything. So once you start entering, you can keep removing, but in the crevice, you might just miss it. So that's where you can use the endoscope.
Thank you. Sure.
Yeah, Professor, now we can finish. I have given my input.
Okay, so if there are no other questions from the audience, maybe we can close this webinar. Thank you very much to our speakers, Dr. Cesare Zoia, Dr. Raghiran Bhuta, for wonderful presentations and active discussions. Thank you, Ishu, for helping me in moderation of this webinar. I want to thank, of course, Raja and Liu for helping with organization as always. And thank you, Professor Yoko Kato, for helping us every time with these webinars, and not only with webinars.
Just Abels.
Yeah. Yes, please. Before I make an announcement, please go ahead, Professor. Go ahead.
Dr. Liu, are you with us now? Maybe we can have us. Dr. Liu, Liu Sensei.
Yes, Professor.
Hi. Just you can make some announcement about how to say. Can you hear? Some
Yes, Professor.
Alumni, some memorable items. How to think about?
Yes. Hello, everybody. Yeah, I think there is a suggestion from Professor for the Fujita alumni member. We are thinking of having a special gift memorable for all the members, which will consist of information about our institution, Fujita Health University, and also we have our SNS logo on it, and also our alumni logo, and probably will be individualized with your name and also the name of the teacher from our institution. So probably we will try to get the suggestion. There are few suggestions. We can have a paperweight. We can also have a plug with a pen holder, or anything that the members think is practical and is memorable for all. Thank you.
Just you can let us know your idea, please, Albert.
Sure. Thank you. It's a very nice idea.
Okay, thank you. Thank you very much.
So
Italian glass, how do you think?
Italian glass might be, yes, from Venice maybe, which is not so far from my place.
A little bit expensive.
It's a little bit expensive,
yes,
but we can try to find a way.
Thank you. Thanks so much. Please go ahead.
Okay, so thank you very much. Before closing the webinar, I would like to invite all of you to the next alumni webinar, which is scheduled in May 7th, Sunday. And we will have Professor Sami as a speaker, so please save the date. Okay, so thank you very much. And we can close the webinar and have a good day or night, depending on where you are.
So yes, this shot will reach Nagoya tomorrow. This shot.
Oh, this shot. Oh, good.
Yes, everybody
Nagoya again.
Nagoya. So okay.